Can you believe it? Another Persiflager's podcast, the Puscast, a review of infectious disease literature with commentary for the last 2 weeks of April 2008. Remember, if you're sick of this intro and you're listening on an enhanced podcast, you can skip ahead to the next chapter. As always, this is on iTunes, and if you like this podcast, go write me a glowing review. This is brought to you by Puscast LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion. Your Uber hyperlinked electronic guide to infectious diseases at Puscast.com. This is CME accredited, so once you're done, take the online quiz and get a half an hour of free CME. Thank you, Legacy Health System. Because this is CME accredited, I have to mention my conflicts of interest. I don't have any, but am desperately trying to acquire some. Somebody please bribe me. Also, all the opinions are those of Mark Crislip, MD, and Puscast LLC, and have nothing to do with anybody else on the planet who has more brains than God gave a goose. The purpose of this podcast is to review the infectious disease literature, and with commentary to claim and pontificate on those articles that are of interest to me. It is not a comprehensive review. If you don't like smart-ass comments, you're listening to the wrong podcast. This podcast will probably contain snide comments, sarcastic asides, and short rants. Don't complain, I didn't warn you in advance. If you are a medical student and looking to become an internal medicine resident, don't forget Legacy Health System tolerates me. They will tolerate you. Also, don't forget the ID Wiki, the feeble attempt, currently languishing in obscurity, to develop a worldwide user-generated infectious diseases textbook, going nowhere on a website near you. And, of course, my Quackcast, a review of supplements, complementary, and alternative medicine, a review also on iTunes. As always, all the literature is online, and you can go there. Thanks to the people who have given me donations to help pay for this podcast. And as always, if you like this podcast, please don't download all the podcasts all at once. I have limited bandwidth, and I'd hate to have my bandwidth exceeded. Then I have to pay more money. Now, on to the literature. As much as I would like to tell you about my spring break with my kid, I got 55 articles in my folder for this podcast, and I got to try and cram them into 30 minutes of random babbling. This podcast may go a bit longer than usual, so let's get to the literature, shall we? One of the recurrent themes of the practice of good medicine is you shouldn't think for yourself. True story. This study concerns the use of heart in women and looked at outcomes if they got the standard heart, as mentioned in the guidelines, or they got some wacky regimen that the doc made up. Guess what? Them what got the standard heart got a higher rise in their CD4 counts and a lower and more sustained suppression of their viral RNA. So those that got appropriate heart did better than those who, left their heart in San Francisco. So following the guidelines, as is so often the case when we review the literature on this podcast, results in better outcomes, be it community-acquired pneumonia or, in this case, initial therapy for the treatment of HIV disease. Follow the guidelines. The ongoing question is, what is the optimal time to start heart when you have HIV disease? Currently, it is thought you should start them, if you follow the guidelines, when the CD4 counts are less than 200. Is this a smart way to go? Smart way. We'll see why I said that in a moment. The reason that they recommend that heart be started at 200 is a variety of issues, including the negative side effects on HIV medications, the inconvenience of medications, the question of increased drug resistance, and limitations on future drug options. However, there aren't a lot of data really to tell you what the optimal time to start HIV medications is. Now, there was the SMART study. You see, there'd be a way I led into this, which looked at patients who had CD4 counts greater than 350. They were randomized either to get meds all the time or to get meds when their CD4 counts drifted down below 250. Then they were started on heart until their CD4 counts came up, and then they stopped it again until their CD4 came down. It should have been called the yo-yo study. Now, the interesting thing is those who had antiretrovirals started at 350 had fewer opportunistic infections, and they had fewer deaths. The problem with the SMART trial is that many of the patients had received prior antiretroviral therapy, so it doesn't truly answer the question, when do you start therapy in HIV patients? But certainly 200 may be too low as to the optimal point with which to start HAART in patients with HIV. I don't know, 200 always struck me as a wee bit too low. Too much of the horse is out of the barn. Clinical trials to look at the optimal time to start antiretrovirals are in progress, and we'll know the results of these studies probably sometime about the time I retire. But until such time, maybe you should start your antiretrovirals a wee bit higher than 200. What that number should be, I don't know, but I'm inclined more towards 300 to 400 than I am 200. And I talk to my patients about the pros and cons of this. Influenza is the gift that keeps on giving, and every year we get new strains of influenza. Where do they come from and where do they go? This was published in Science this month, and they looked at an amazing 13,000 strains of H3N2 influenza from 6 continents from the year 2002 to 2007. And when they watched the genetic changes in these organisms, amazing what they can do these days, over time, looking at the genome, they found that it looked like the virus would start always in Southeast Asia. It would then spread across the world, end up in the temperate zones, and peter out and disappear. The interesting thing is it would appear that the strains that were found in temperate zones, such as North America, had no influence on subsequent genetic variations in the influenza virus. Why do you care? Well, at the end of every flu season, they have to pick next year's vaccine based on circulating strains. So it looks like you can pretty much ignore the North American strains, for example, if this pattern holds out. But it would appear that flu usually starts in Southeast Asia and spreads to the rest of the world, and each strain subsequently goes away. As we talked about in the prior podcast, mumps has made a slight resurgence, and in 2006, they had almost 7,000 cases of mumps in the United States. This was primarily in the Midwest, and there was a big outbreak in Kansas, so they had an opportunity to see how good the vaccine was, which was the purpose of this study. And they looked at patients who had had both doses of the MMR and compared them to controls to see what the risk factors were for having mumps. It would appear that the secondary attack rate in patients who developed mumps, despite having the vaccine, was somewhere between 2 to 7%, which gives you a rough idea of the efficacy of the mumps vaccine, which should be about 95%. It would appear that the longer out you were from having received your second dose of the vaccine, the more likely you were to develop mumps. And for each year after the second dose, your risk went up for mumps. So the risk for developing mumps is probably if you had the vaccine 10 years prior to exposure, and then your risk still was low, but on order of 5%. Currently, the recommendations is that all healthcare workers should be immunized to mumps and either have evidence of immunity or get the vaccine. Unfortunately, you can predict that despite that, if there is a mumps in your hospital, about 5% of your immunized employees may get the mumps if they hadn't practiced proper infection control procedures. So what do you use for odontogenic infections? The tradition for years has been penicillin or amoxicillin, but resistance to both streptococci and anaerobes are increasing to those agents. And the same is probably true to the other standard, which is clindamycin. Depending on where you look, at least a third of anaerobes and a third of oral strep can be intermediate or resistant to clindamycin, making its utility in odontogenic infections somewhat suspect. This study was published in an abstract and reviewed in Medscape, which looked at moxifloxacin versus clindamycin for treating odontogenic abscesses and inflammatory infiltrates in the jaw secondary to bone infections. Now, the problem with this study is that there was no microbiology, so you don't really know why one drug worked better than the other. But patients were randomized to receive either 5 days of moxifloxacin or 5 days of clindamycin. And then what got the moxifloxacin had a more rapid decrease in their pain and And those in the group that had abscesses, both were better at 5 days, but that's probably insufficient duration of therapy. There was no difference in the clindamycin versus moxifloxacin group if you had an odontogenic abscess, but the overall numbers were better for the moxifloxacin group. There should be less resistance to moxifloxacin for oral flora. Again, this was not a microbiologically driven study, but I'm not surprised that moxifloxacin did better than clindamycin. And given the increasing resistance to the common oral agents, this may be a good alternative to patients for the treatment of odontogenic infections. If I had a bad one, I'd be inclined to give moxifloxacin plus metronidazole, with my bias towards maximizing anaerobic coverage if I had an abscess, but that data is not available. This is a warning for Ben Stein. Please skip ahead to the next paper discussion, as the current one may cause you to kill people. The current article under discussion is about the emergence of resistance to antibiotics, and this was quite interesting. What they did is they took two disparate populations in Israel, Jewish children and Bedouin children, and they looked to see if giving antibiotics was associated with changes in susceptibilities to strep pneumo. Now, there are times of the year when they give far more antibiotics, and there are times of the year when the kids get less antibiotics. They looked at almost 250,000 antibiotic prescriptions and over 3,000 strains of pneumococcus, and found that indeed in the time of the year when antibiotic usage went up, so did the resistance of strep pneumo to common antibiotics. And in times of the year when the antibiotic usage was down, antibiotic susceptibility increased. Now, this was mostly true for penicillins and macrolides, and it was not true for cephalosporins. And there was some variation in both populations as to which antibiotics were associated with increased resistance rates. But this would appear to be, plug your ears, Ben Stein, evolution in action. But it does give reason to suspect that if you don't give antibiotics unnecessarily, which we do a lot of in medicine and in veterinary medicine, perhaps you'd see less resistance in your community to the common antibiotics. The motto, of course, is use it and lose it. So you have an MRSA infection. So you have three pieces of crap to choose from. Crap number 1, vancomycin. Crap number 2, linezolid. And crap number 3, daptomycin. Which drug should you use? Well, this study, which was published in abstract form and mentioned in Medscape so far, looked at the comparison between vancomycin and linezolid for the treatment of soft tissue infections, and found that vancomycin was the same as linezolid when it came to overall cure rates. However, for subpopulation groups such as abscesses, diabetic ulcers, and skin ulcers, there was a slight advantage to the linezolid group, and there was also benefit in terms of length of stay, which was about 2 days less in the linezolid group. And eradication was more common in the linezolid-treated group as well. So what can you say about this study? Well, it would appear that for all comers that vancomycin is equally bad as linezolid, and there may be a slight advantage to getting linezolid for complicated soft tissue infections. The downside is to this study, I love it, I have to quote the end of it, the study was supported by Pfizer. Dr. Geringer has disclosed no relevant financial relationships. So the downside is this was a drug study company looking at the drug, and we all know that this is often indicative of a slight bias in favor of the financial sponsor. I think it's safe to say, though, that drugs are equally bad, and that the nice thing about linezolid is that resistance should develop a lot faster than it does to vancomycin, so the linezolid era for treating MRSA will probably be a short one. Repeat after me. Association does not equal causation. Be that as it may, what happens if you get MRSA versus MSSA infection whilst you're in the hospital? This study looked at long-term follow-ups of anybody who had a culture positive for MRSA or MSSA from any site, and they looked at long-term outcomes. And if you had a staph infection, 42% of people were dead in a year, which is pretty impressive. Marker for mortality. probably a marker of underlying diseases to get a staph infection. But if you had MRSA, you were much more likely to be dead at 3 months, 6 months, or 12 months. The 12-month mortality being 51% if you had MRSA versus 32% if you have MSSA. So getting colonized with staph probably increases your chances of developing a staph infection. Getting a staph infection and surviving it probably means you got a 50-50 chance of being dead in a year. So the take-home message is if you're in the hospital and you get an MRSA infection, don't buy any long-term magazine prescriptions, whichever. If you get colonized with MRSA, there's about a 1 in 3 chance you're going to get infected in the next year. But the depressing thing is if you get infected, you're going to get infected a second time. This study was looked at in clinical infectious diseases where they found 27 patients who had recurrent MRSA infections, and it was the same strain virtually every time. Unfortunately, if you treat someone with a course of vancomycin for their MRSA infection, you probably do nothing for their colonization rate. And many patients have underlying problems which are going to predispose them to continued colonization with MRSA. But you should probably give consideration with an MRSA infection towards the end of therapy of trying to decolonize them and their environment with Hibiclin showers, topical Bactaban, and a terminal cleaning of their house. But it may very well be that, unlike love, MRSA is forever. Universal screening for MRSA is probably the wave of the future, and it's probably effective depending on local conditions. But how should you screen? Should you screen with routine cultures, or should you use one of the new fancy schmancy rapid techniques like PCR? This study was out of England and looked at screening in wards of a large hospital. Some wards got standard culture techniques, some wards got rapid, i.e. PCR-based identification of MRSA. Then they were crossed over. And the interesting thing is there was no difference in the two techniques for preventing the acquisition of MRSA and MRSA infections. There was a more rapid use of appropriate hospital beds and cohorting, but otherwise they found that the use of the PCR-based techniques for determining the presence of MRSA was not cost-effective and not better than using standard techniques. The machines for rapid screening evidently cost $250,000, which would pay for 10 infectious disease doctors. So it's probably not a worthwhile investment based on this study for your institution. Members of the Discovery Institute should not listen to the next entry as well. This one is a quickie. It concerns the use of linezolid and enterococcus. And guess what? The more linezolid you use, the more resistance in enterococcus you see. In my own little pond, there seems to be an increased use of linezolid for MRSA, given the mechanism of action and how easy it is for mutations to occur to this antibiotic. You would think that you were going to see the rapid development of linezolid resistance. You heard it here first. Those from the Discovery Institute can take your fingers out of your ears and quit making ma sounds, and you can start listening again. There was the suggestion in 2005 that there was an association between the quadrivalent meningococcal vaccine used in the United States and the development of Guillain-Barré syndrome. A follow-up from the CDC suggests still that they can neither prove nor disprove an association. In Canada, they looked at whether or not the monovalent vaccine to meningococcus type C was associated with an increase in Guillain-Barré during a mass immunization. And they found no increased risks of Guillain-Barré if they had a vaccine or not. So at least with the monovalent type C, there appears to be no relationship between the development of Guillain-Barré and receiving the monovalent meningococcal C vaccine in Canada. So that's good news, eh? If you don't know, and you should know, and nobody knows noses like neosynephrine, that you should not use daptomycin for the treatment of bacterial pneumonia. The study that was published in Clinics of Infectious Disease looked at the studies that demonstrated that daptomycin is not effective for pneumonias. due to strep pneumo or Staph aureus. And this is because there's essentially no effective drug in the lung. Now, the interesting thing is they discovered in reviewing their studies that in these clinical studies, patients sometimes got 24 hours of empiric therapy before changed over to the daptomycin versus ceftriaxone study. If the study patients received even 24 hours of an alternative agents and then were put on daptomycin, their cure rates were those of the comparator agents. The importance of this is that it's difficult to evaluate clinical trials where patients receive some random empiric therapy for a day or three before being randomized to study drugs. The prior antibiotics may have a significant impact on the disease, even if it was only for 24 hours. But again, the take-home message is don't use daptomycin for pneumonia. An ounce of prevention is worth a pound of cure. Or as I've said before, an ounce of perversion is worth a pound of pure. You can prevent pneumonias or you can cause pneumonias depending on what you do. This study in the geriatric literature, specifically the American Journal of the Geriatric Society, looked at 23,000 elderly people and their use of antipsychotic agents. And patients who received antipsychotic agents, especially the atypical antipsychotics, had a 60% increase use, usually in the first month of developing a pneumonia and subsequently developing death from that pneumonia. The deaths were primarily cardiovascular events, and we've talked in the past how infectious diseases cause a prothrombotic state that increases the risks of myocardial infarction and pulmonary embolism. Why the use of antipsychotics was associated with increased pneumonia rates was not elucidated in this study. I would presume it's the altered mental status that occurs in the sedation with aspiration. But if you have a patient who gets put on antipsychotics, in the next month or so, really watch them and use the preventative measures for pneumonia, such as keeping the head of the bed. Be careful of the tests that you use to develop PJP, that's peanut butter and jelly pneumonia. This study looked at 172 HIV patients who were infected with community-acquired pneumonia, and they used PCR on their sputum to look for the PCP DNA, and they found that 68% of patients were, quote, colonized with pneumocystis. And pneumocystis colonization may be fairly common in patients with HIV. In a study out of Clinical Infectious Diseases, they looked at the spread of PJP within families. I keep calling it PCP because I'm an old geezer who can't change their ways of speaking. But they took normal AIDS patients and they looked to see by PCR if they had PCP, and they found that 11% were carriers and 3% of their children were carriers of pneumocystis, but they were not clinically infected. So PCP is part of the normal flora, and if you get a sensitive enough assay for PCP or even PJP or LSMFT, you may find the organism, but that doesn't necessarily mean clinical disease. There's always this ongoing issue as to whether C. difficile is resistant to metronidazole or have decreased susceptibilities to metronidazole. This study was at the European Congress of Clinical Microbiology and Infectious Diseases and reported in Medscape. This series looked at a series of C. difficile ribotypes and their susceptibilities to metronidazole, and they found that one ribotype 001, had an increase to the MIC to metronidazole of about 4 milligrams per liter, which is about 4 to 20 times higher than the other ribotypes. They found that within this ribotype, 25% of strains had a decreased susceptibility to metronidazole. Now, our routine clinical labs have no way of testing for C. difficile susceptibility, and the ribotype 001 was not the common strain, but over time it would appear. And not unsurprisingly, again, those of you from the Discovery Institute don't listen, that there's increasing evolution of resistance to all antibiotics, including C. difficile and metronidazole. We've talked about the goofball contingent that likes raw milk and thinks that pasteurization is evil. And we've talked about some of the infectious diseases that you get from unpasteurized milk. We can add to our list of infections acquired from unpasteurized milk Salmonella serotype Newport, which had a big outbreak in Illinois with the consumption of unpasteurized Mexican-style aged cheese, and they traced it back to a farm which had cows that were excreting it in their milk that was identical to the strain found in the cheese. So if you're going to be drinking your raw milk or eating your raw cheese, not only are you at risk for Campylobacter and Listeria, you can add outbreaks of Salmonella to the list. It also brings to the forefront of keeping an eye out for unusual bugs in your community. Salmonella type Newport was unusual in Illinois, and that led to them looking for outbreaks secondary to the milk production. So if you start seeing a smattering of unusual strains of organisms in your community, look to the diet of your patients, amongst other things. Fecal oral. I love that term, but in reality, we are all awash in each other's stool all the time, and we give each other infections as a consequence. However, you don't necessarily need to eat each other's stool. This study looked at an outbreak of shigatoxin-producing E. coli 017 in Wales, where they had 22% of households had secondary spread from the index case to other members in the family. And it turned out that if you were to isolate the child with the Hershey squirts and the E. coli, you could prevent a significant, probably at least half of subsequent spread of this disease within the family. So the take-home message from this Clinics of Infectious Disease study was that if you have a case of E. coli OH157, it's important not only to isolate the patient if they get admitted to the hospital, but you should apply the same contact isolation procedures within the family. The standard is always to write for blood cultures when the patient is having a fever spike, presumptively because you're going to get the organism. But is that a reasonable thing to do? This study, which was published in the Journal of Clinical Microbiology, looked at the timing of blood cultures in relationship to positivity of blood cultures in almost 1,500 patients. And they found that there was not an enhancement of positive blood cultures by waiting for the patient to have a fever. And that's very reasonable because it probably takes from the time of bacteremia to the spiking of a fever a couple of hours. You get bacteremia, which has to excite the macrophage, which has to make tumor necrosis factor, which has to excite the thalamus, which has to have a rigor, which then has to have a fever. And that process takes a couple of hours. And most bacteremias and most fungemias are sporadic or intermittent. So most of the time, when you're obtaining blood cultures because of a fever, you've missed the window of opportunity by an hour or two. Your best bet when ordering blood cultures is to order them 2 hours before the onset of fever. Being psychic, I have no problems doing that. Now, I'm going to go out on a limb here and say that getting endocarditis is a bad thing. But long term, it's also a bad thing. This study looked at survival rate in patients of endocarditis over time, up to 20 years later, and found that survival rates were not as good as one would like. At 2 years, it was a 95% survival rate, which is pretty good. But at 5 years, only 82% were alive. And at 10 years, 66% were alive. And by 20 years, fully half of people were dead. The big thing that led to death was development of heart failure. Now, the annoying thing about this study is that patients who had early valve surgery had better long-term survivals. This is, I think, the third study to show that patients who have early valve replacement for endocarditis do better long term. I say this is annoying as the vast majority of endocarditis patients I see are IV drug users, and sticking prosthetic valves in them is not a thrilling thing to do. Although in this study, having surgery within 3 months of your endocarditis was associated with better long-term survival. Now, whether that was because these patients had indications, i.e. valve failure, which is the usual reason for replacing a valve, and that's why they did better, is not clearly elucidated in this study. But it may be that them what had signs and symptoms and need for endocarditis did better than the long-term because they were sicker up front. I think this is going to be a 45-minute podcast this month. Now, 29 minutes and 16 seconds into the podcast comes the most important study published this last 2 weeks in Clinical Infectious Diseases. This study looked at the use of clarithromycin in patients with sepsis and ventilator-associated pneumonia. They had 100 patients who were randomized to receive a gram of clarithromycin once a day for 3 days, and 100 patients who got placebo. Them what got the clindamycin were less likely to die had more rapid resolution of their sepsis and had more rapid resolution of their ventilator-associated state, which is an awkward way of saying they got extubated faster. Why might this be? Well, one of the effects of clarithromycin is that it inhibits the pro-inflammatory cytokines that are found in human mononuclear cells. So in this study, it was used as an immune modulator in patients with sepsis and ventilator-associated pneumonia. The downside of this study is if you were going to die, you took longer to die. Now, there are also the possibility that the reason that clarithromycin is effective is it's messing with virulence factors on the organisms, but often the organisms that cause ventilator-associated pneumonia and sepsis are not amenable to treatment with clarithromycin. I think this is a fairly compelling study, and it should be a reasonable thing to do in sepsis patients in your ICU. In this study, they got better from their pneumonia 5 days faster and got off the ventilator 6 days sooner. That's pretty significant alteration in the clinical course of ventilator-associated sepsis. So clarithromycin, 1 gram a day for 3 days in sepsis and ventilator-associated pneumonia. Let's see now. I'm fat, and I don't want to pay to have my fat removed in the United States because it's expensive. Why don't I go to, Central America? Yeah, they're well known to have great health care, and let me have my abdominoplasty there. Well, there was an outbreak of people, the so-called lipotourists, who went to the Dominican Republic for abdominoplasty to get their adipose removed, and they had an outbreak of Mycobacterium abscessus. There are now multiple cases of patients getting infections secondary to lipotourism. Let me tell you, you don't go to third world countries to get surgery done. They're not exactly noted for their sterile technique. On the other hand, infectious disease doctors need something to do, so maybe everybody should go to third world countries for their surgery. Also, by the way, there have been a couple cases now of atypical mycobacteria associated with body piercings. I've seen a couple people lose their ears over the years when they've gotten staph or pseudomonas in their ear piercings because they had it go through the cartilage rather than the fat of their lobe. But atypical mycobacterium are also now on the list of things that one can pick up from getting a body part pierced, and you need to send special cultures if you get culture-negative body piercing infections. That's one of the many things that mark me as 51 years old. I don't get body piercings, I don't get tattoos, and I don't get hip-hop. My son listens to a lot of hip-hop these days. Ugh. The 5 classic risk factors for developing fungemia due to Candida albicans are central lines, broad-spectrum antibiotics, hyperalimentation, major abdominal surgical procedure, and cytotoxic neutropenia. But that's not necessarily the case for non-albicans Candida species, as noted in this clinical infectious disease article. They found that the risk for getting a bloodstream infection due to non-albicans Candida was having a CVP and getting fluconazole. The use of total parenteral nutrition was associated with a decreased risk for non-albicans Candida. So fluconazole, for good or ill, is probably helping to select for fungemias due to Candida that is not Candida albicans. The extensive use of the imidazoles is probably part of the reason why Candida albicans is no longer the leading cause of candidemia, especially in hematologic malignancy patients, where Candida glabrata and Candida krusei, which is intrinsically resistant to fluconazole, lead the list as the leading cause of fungemia in patients with hematologic malignancies, as pointed out in the journal Cancer. These, of course, were all neutropenic patients, but Candida parapsilosis was the leading cause of catheter-related fungemia in the study. So this is part of the reason why it's my understanding that when the Candida guidelines come out later this year, they're going to be recommending that initial therapy with patients be with a echinocandidin antibiotic rather than an imidazole-type antibiotic. Certainly when I suspect Candida or have a blood culture that's showing a yeast, and I don't think it's Cryptococcus, I start patients on caspofungin first now rather than fluconazole or one of its cousins. Just a little FYI, the New England Journal has a review of the use of artesunate for the treatment of severe falciparum malaria, and the Clinics of Infectious Diseases has a review on the epidemiology, resistance, and treatment of Acinetobacter baumannii infections. I'm not going to go over those in detail, but the links are on the website. Can you give me a yippee and a skippy and a yah and a who? We're at the end of this podcast. For the last 2 weeks of April 2008, the Puscast, the Persiflagers podcast to review infectious disease literature with commentary and snarky asides. Remember, references, including some not mentioned in the podcast, are available on the website. Now that you've listened to this, go online, take the quiz, and get a free half an hour of CME. Thank you, Legacy Health Systems. Brought to you by Puswell LLC, the publisher of the Persiflagers Annotated Compendium of Infectious Facts, Dogma, and Opinion. Your Uber hyperlinked electronic guide, free at pusware.com. Remember, if you like this, go on iTunes and write me a glowing review telling the world what a wonderful podcast this is. And if you like this sort of nonsense, listen to my Quackcast, an occasional review of supplements, complementary, and alternative medicine, i.e. scams. And because the world needs more of me, I'm now an occasional blogger on the science-based medicine blog. Yes, the world needs more Mark Crislip. Don't forget that Good Samaritan Hospital has a wonderful residency program that if they tolerate me, they will tolerate you. And still, as we talk, languishing in obscurity is the Infectious Disease ID Wiki. Please join in, do some writing, give us a world-class, user-derived textbook of infectious disease. Bandwidth ain't free, so feel free to purchase this compendium and support the podcast. But most importantly, if you like the podcast, don't download them all at once. Download them as you need them. That will not strain my bandwidth, and then you know how painful it is to have a strained bandwidth. Copyright with the Creative Commons license, www.creativecommons.org. The music is by my 12-year-old son, improvising on the guitar. He's now 14 and even better. I need to record some more music. For comments or snarky asides or letting me know how disappointed you are with me as a physician and a human being, email me at mcrislip@pusware.com. As always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.